Hello, Professor Jan Wernerman. We're here at the ESICM in Paris. Professor Wernerman has worked in Karolinska Hospital in intensive care for many years, and I am Blogg here with Nestlé Health Sciences. So we heard a controversial debate this morning on is earlier better for nutrition in the critically ill population. And it seems that overall the conclusions are undecided. There's not enough data.
No, I disagree with you, because I think that everybody in the panel, and I heard nobody in the crowd who was against early nutrition. Problem is how to select patients to be very early. And the problem is when patients are ready to receive full nutrition. I think everybody agrees that we should start nutrition. So there is no controversy along that. I wouldn't call it a controversy, but I would rather call it difficulty to realize how much you could give to the individual patient. What are the signs, the clinical signs, or the biochemical markers or whatever to guide you how to advance nutrition?
So there's lack of concrete guidance in the specifics about nutrition.
I think it's another thing that was not controversial is that there is no cookbook. A lot of people would like it to be a cookbook, and you know on the second day you can do, on the third day you can do. There is no such things, because the time course for the individual patients in this extremely heterogeneous cohort doesn't look the same. So you have to use your clinical skills and to integrate all the type of information that you have to decide how to do.
And this will always be the case in intensive care,
won't it be? Yes, it will.
So is it unrealistic trying to define guidelines somehow?
I think guidelines has to be phrased accordingly. That means that you should go away from saying full caloric support should be given in 48 hours or something like that, because this may be correct in some cases, but it actually may even create harm in other cases. And on the reverse, as what also was stated, to not give full nutritional support in 48 hours may do harm in other cases. So when you randomize huge group of patients into rather rigid schedules, you will probably help some patients and you will probably harm some other patients, and very often they equal out, so the conclusion of the study is undecisive.
So how do you manage this in a day-to-day world at the bedside in intensive care?
It's not that difficult, but I would emphasize that everybody who do intensive care medicine, and in particular nutrition in the critically ill, must be comfortable with knowledge in metabolic basics. And if you are not, then you of course are in trouble. Then you are looking for the cookbook, and then it's very easy to come wrong. But I think anybody who gets the professional skills, and everybody who remembers this type of basic physiology and how the physiology change in response to the different trauma, sicknesses or whatever, this is important. The insulin resistance, the inability to suppress mobilization of endogenous substrates, for example, all of this is very, very important. Otherwise you may go wrong, you may overfeed. And recently we also come up with this refeeding-like syndrome, which is usually come to attention by a drop in phosphate in response to start of feeding. And it's unfortunate that we presently are not very well aware of the mechanism behind this, but from observational studies it's clear that full nutrition in these cases do harm, actually even on the mortality level. So it's important, and what happens doesn't happen immediately, it happens over time. So if you full feed patients in the early phase who show this drop in phosphate, you compensate for it, so you normalize the level, still they have an unfavorable mortality outcome in the next few weeks. So in that case, it's an example when knowledge of the basic metabolism isn't good enough, because we are global knowledge is not good enough. So many people think that we know the alterations in metabolism in response to trauma, sepsis and so on, but I disagree with that. I would like to emphasize that there is still a lot to do. And I mean, this is a research phase of research area for myself and my research group, and very often we have the comment that you are investigating old things, these are well known, but I don't agree to that, because it's not well known, and in particular the temporal pattern of these changes is not well characterized.
Well, you're an expert in this field, not only in critical care but also in metabolism and nutrition. Is it reasonable to expect other intensivists to have this passion, this knowledge, when they have a lot of other priorities managing the critical care?
Of course, as an intensivist you will have a profile. Somebody is more interested in infections, somebody is more interested in central circulation in the acute phase, so you will have your profile of expertise. But I don't think that you can call yourself an intensivist if you don't take this into account. You have to have a minimal pass level on all important fields. I mean, you can't disregard the psychological parts of it. I mean, you have to recognize how to handle families. There's a lot of things that you have to do as an intensivist, and you can't be an expert in all fields, but there is a minimal pass level, and if you are below that, you should consider doing something else.
So it's really an art and adapted to the individual patient.
Definitely. I mean, just like somebody said this morning, I mean, you don't give noradrenaline on a certain infusion rate on day 1 or 2, but you have parameters, and there is controversy what parameters is good enough to dose your noradrenaline. Should it be blood pressure? Should it be lactate and so on? So, I mean, nutrition or metabolism and nutrition doesn't stand out. It's just like the others, but the difficulty is that markers like blood pressure or lactate, as I took in the circulation, these are not readily available actually. So how should we reduce it? I mean, we look upon, for example, gastric retention, and it's controversial how that should guide your enteral nutrition, but it's something that we do and that the nurses like to do, and we take it into account. But also, I mean, even if it passes the stomach, is it readily absorbed? How is it utilized? And also for parenteral nutrition, even if it's given intravenously, you can't be sure that it's utilized by cells in the way that it's utilized. And I think the insulin resistance, for example, to take an example, is a good marker for that. So it's an art, like you say, and you look upon biochemistry, you look upon blood sugars, ureas and whatever, and you adjust your nutrition accordingly. That's the way I can say, and I think the guidelines should focus upon early enteral nutrition, as we all agree upon. You should start as early as you can, but in my institution we usually don't start enteral nutrition until we have secured airways, for example. So there may be an early period when we don't know if we are going to secure airway by intubation or how we would do, and then perhaps the nutrition is just by a small amount of dextrose or something like that. So, but you've got to have a protocol, and then you have to adjust it to the individual patient. I mean, there is no shortcut, if you ask me.
Thank you very much. It's a complex story. It sounds like we're just at the beginning.
Yeah.